part, just I want to introduce our second discussant, who's flown all the way from Calgary, Mike Pietrus from the Mental Health Commission of Canada.
Thank you very much. It's very difficult to add on so much of what's been said tonight, but the first thing that I would like to address is the incredible courage it takes for people who have a lived experience to come forward. Person over here, and Mike Santoro, to tell their stories and to begin to demystify and normalize, I guess for lack of a better description, this whole issue that we're dealing with mental illness. I mean, I could throw out lots of statistics for you. For example, 2/3 of people with a mental health problem won't come forward to seek help. The main reason for that is because of the stigma that we've heard about today. People don't want to be labeled. That whole idea of somebody being labeled as dangerous, unpredictable, no longer a contributing member of their community or their workplace. It's always interesting to see and hear stories about how someone comes forward in the workplace, for example, who has cancer, and their colleagues rally around them, and their boss will usually say, whatever it takes, we want to make sure that you get through this and we'll be there for you. A very prominent psychiatrist from this city is on a video that we have, and Manon Charbonneau, who's past president of the Canadian Psychiatric Association, tells her story. She had cancer, and all of her colleagues and people rallied around her, and she talks about the letters she received and the flowers, and everybody always talks about casseroles too, so she received casseroles. But interestingly, after her treatment, she developed depression. And she said it was a completely different experience. She said the cards stopped, the flowers stopped, people didn't get behind her and give her the important support that she needed from her community and her colleagues to help get through this. So it's really a very interesting and complex situation. At the Commission, we're trying to approach this in a somewhat different way, and it's in large part to the work that Heather has done before us in the World Psychiatric Association, in that rather than getting out there and falling into the same trap of reinventing the wheel, of getting out there and running really expensive social marketing campaigns without having the products or ways of engaging people, can be a really futile exercise. If you look at what the international literature says, it essentially says once these social marketing campaigns have disappeared off of the public airways or no longer in ads in newspapers, people forget about it. Or you also have to be careful, because if you're drawing attention to this issue and something awful happens within the news media that focuses the attention on a negative aspect of mental health, you can actually create harm or drive people to a different belief, and actually rather than supporting the cause, they can actually take a negative attitude, and you move them to a different place. We have 3 principal target groups presently, actually 4 if you include the media. I'll talk about 3 very quickly and then talk about what we're doing as far as the media is concerned. So 2 of the initial target groups we had coming out of the gate when the Commission first started, youth and healthcare providers. The reason for youth is because of the early onset of mental illness, and the importance of early diagnosis and intervention and treatment can make such a dramatic difference in the quality of someone's life. Healthcare providers, as we've heard, interestingly enough, but not really surprising, is that some of the worst stigmatization takes place on those front lines where people are actually going to get help and support, and in fact get turned away or so turned off that it's very hard for them to come back. And again, it all has to do with the labeling. When you look at it, and I'm not trying to make excuses, it's not often deliberate, sometimes it's unintentional. When people in the medical profession, for example, are always seeing people in crisis, they can sometimes begin to think that everybody with a mental illness is like the person that they just saw in their emergency department or in their office. That's no excuse for them. I'm not saying that at all. But you can begin to see how that begins to develop. So one of the key ingredients that we're using with our work is something called contact-based education. And I think you saw 2 incredible examples, 3 incredible examples of contact-based education here. People with a lived experience who are managing their illness or have recovered from their illness have an opportunity to talk about what they've been through, what they're experiencing, and it creates a whole different dynamic and really begins to help people better understand but also connect. So all of a sudden you could look at the person who's speaking and say, wow, they're just like me. They're not unpredictable, they're not dangerous, they're not going to threaten me. It's somebody, you know, dealing with a problem much like I might be dealing with that same problem. So that contact-based education is very important. And I'll sort of talk about some of the programs that we're dealing with in a second. The other area that we're dealing with is the workplace. It's very, very important to break down those barriers in the workplace. Oftentimes, if you do come forward, it can be a real career-limiting move. And also, you need managers who are understanding, and you need systems in place so that those accommodations are there for people. The fourth group that we're dealing with is the media, and you've heard about Rob's study and the study that Sarah and the group here are working on. One of the other things that we're trying to do is work with journalism students. So we have been traveling across the country presenting at journalism schools. Andre has been one of the presenters, so has Rob Whitley. One of the important aspects, and I think not to take anything away because I think they're always well received, but invariably it's the people with lived experience who tell their stories to the journalism students that really strike a chord with those young people. And we're really sort of beginning to try at an early stage to get people to take a whole different look at how they view mental illness and mental health. And we've done some studies, and Heather, if you want to stick around a little bit later, can talk to you about some of the successes we've had where we've actually really begun to see a change, not only in you know, acceptance, but also in terms of a better understanding, so that we do a pre-test before the students undergo the intervention, and then we do a post-test after it's over, and you can see some really positive changes in terms of intended behaviors, in terms of reduction in social distancing and things of that nature. So it's a small place to start, but we think it's an important one. Rob talked about guidelines. We'd like to work with media groups about developing guidelines or have them develop guidelines. We haven't been too successful. As a former working journalist for almost 30 years, the media hates guidelines. They prefer to be unfettered and you know, do it on their own level. But I think Andre gave us some excellent examples about how we can work with the media, how we can use various forms of pressure to try to subtly influence the media and not so subtly. Again, we want to watch out about protests and things of that nature, but at the same time, I think we can also, you know, like so many other stigmas that existed in the past, really begin to use the media as a positive influence. Again, some of the programs that we're working with, we're trying to use contact-based education in some of the programs with medical school students, with pharmacy students, with nursing students. We're developing programs actually that are aimed at practitioners who are in the field now and other healthcare providers, and we're seeing some very, very positive results that are coming from those programs. The other thing it's allowed us to do is also identify gaps. There are a lot of good programs out there, but there are groups that are sometimes difficult to reach. One of the groups that we've identified that's difficult to reach are doctors. They're very busy, and sometimes they don't think they're part of the problem in terms of stigmatizing people. So we've been working with a consortium to develop an online accredited program which doctors can take and get credit for, which is really an introduction to helping reduce stigma. And it's based on a very successful program out of British Columbia. So in the process of our research, we've been finding successful programs, and what we're trying to do is replicate and promote those programs. So that's where social marketing can actually have a very positive effect, when you begin to actually move people and actually engage them so that there are things that they can tangibly do, as opposed to walking to raise money or things like that. There's nothing wrong with that, but if you can get people to introduce better programs into the school where mental health is addressed in a much more meaningful way than it is right now, I think that's very important. And that's just one small way of changing the system. Thank you very much.